Okay, so thanks again, Anthony. Next up on our agenda is Jeff Sewardson, the John C. Malone Professor of Biomedical Engineering and Professor of Computer Science and Radiology. Jeff will discuss how we can combine clinical data and imaging to build models that predict the likelihood of good treatment outcomes.
Excellent. Thank you, Dr. Berger and Dr. Rosen, for the great introduction. And good day, everyone. Share my screen now. And you should be seeing a title slide now that says Imaging for Precision Medicine. I'm going to focus on the topic of imaging primarily in the context of surgery. And even just 5 years ago, we would have spoken about this in terms of spatial precision or millimeter precision, making sure that surgery is delivered very accurately to a target of interest. But today I'm going to talk about how imaging and in terms of defining phenotype subgroups individualizes surgery. And so it's really within this context of precision medicine. And toward the end, I'll invite you to think about how imaging as a form of measurement combined with deep analytics expands that capability beyond surgery to other areas, including even COVID-19. Spine surgery, as a specific example, is an extremely large market and presents a large societal burden and healthcare cost burden as well. There are 3 million spinal fusions per year. It's a $12 billion market. And it's not only a large market, but it's increasing by 32% in a decade overall, and even more so, 73% increasing in that same decade for the more elderly. And the costs are accelerating as well, with a 150% increase in cost over that same time period. You can see it's also a very technology-rich area of surgical specialty with surgical navigation, guidance, and robotics, intraoperative imaging, and so forth. Unfortunately, it's an area that's challenged in the variability of its outcomes, and some outcomes can be pretty poor, with somewhere between 13 to 19% of patients receiving no benefit in pain or function, and upwards of even 25% rate of readmission to address some form of comorbidity or revision of the surgical product. And so those outcomes have earned spine surgery some bad press. You may have seen these types of headlines where whether certain spinal fusion surgeries are necessary and why so-called useless surgery. If you think about in terms of those fractions, it's potentially billions of dollars of surgery delivered without a benefit. And so we want to address some of these large questions through approaches that give us a better handle on predicting the outcome of a particular patient, providing a means of decision support to patients and their surgeons. Conventionally, this is done by one's understanding of what I'm referring to here as clinical and demographic data, which is captured within the electronic health record, and combining what we know about individual patients' clinical and demographic status with outcomes of physical health, mental health, and so forth, pain and function. And from that, predicting the outcome. But as we saw within this sort of conventional scheme, that our ability to really understand whether an individual patient is a good candidate for surgery, or what the best surgery or rehabilitative pathway for a patient is somewhat limited. And so what we are adding to this picture is quantitative image analysis. And so that's illustrated here in terms of the extraction of quantitative high-level image features from a patient's perioperative image data. So this is really image data that are acquired around the patient's operative procedure already, and from preoperative images or diagnostic images and so forth, that we're able to extract quantitative features that will help us understand subgroups and predict an individual's path. And these include some of the things shown here, where just the ability to, first of all, certainly identify which vertebrae are associated with disease, what aspects of spinal curvature or global spinal alignment are pertinent, how devices should or would be delivered within the context of surgery, and what's the role of paraspinal tissue morphology, fat and muscle surrounding the spine. Currently, I would say these are certainly incorporated in understanding of the decision support for a patient, but are done so qualitatively. So the ability to quantitatively extract these kinds of image features, combine them with what we know about a patient's clinical and demographic status, can empower some more advanced predictive measures, machine learning or deep learning or artificially intelligent systems that are able to ingest lots of these kinds of information about a patient and give us a prediction of outcome and shape a decision support for the surgeon and patient. For example, a system that could help the surgeon and patient understand, is this a good patient candidate for surgery? Are there factors that are likely to improve their outcome? I hope what you see reflected here is what Dr. Berger referred to as the ability to measure, right? And Dr. Rosen mentioned imaging as an important aspect of the measurement continuum, combined with analytics, deep analytics, and the increase in connectivity of information within medicine. And so all those features are evident here in a system for spine surgery that we're developing. We refer to that as Spine Cloud. I'm just going to touch on three of the important elements of Spine Cloud in extracting those high-level features in order to be able to scale that kind of system rather than to tailor and manually define all those features for an individual. We have to be able to do things automatically. And so I'll touch on just three of the systems that we use to extract information automatically from images. And the first, of course, is to be able to automatically label the vertebrae within a patient's image. And that's just illustrated here, where a patient's volumetric CT is analyzed by a system that we've developed called Ortho3D. It's a set of artificial neural networks which accomplishes the task of identifying vertebrae, understanding what is not a vertebrae, what is a vertebrae, clustering the detections, and accurately labeling the vertebrae within the image. And it, as you see here, it does so with a precision and recall around 93 or 99%, and gives you the kind of variability that's comparable to what an expert human observer would define as the center of this vertebrae, and is able to label it with accuracy of a few millimeters. That's a simple example, but it starts to feed some important systems. For example, given those vertebrae, we can start to understand aspects of global spinal alignment. And some of the measurements of global spinal alignment are shown here: lumbar lordosis, thoracic kyphosis, and so forth. And so you can imagine how those labels can start to feed systems that automatically analyze the alignment of the spine and extract features that would be conventionally measured manually. And in fact, the automatic measurements are able to reproduce the expert measurements within about 93.5% of the time. In other words, the automatic method agrees with about 95% of the observers and about 93% of the time. And a final example is just to automatically extract information on the surgical instrumentation itself. First of all, where should the instrumentation go? And so we developed a method that takes the patient's preoperative CT and automatically determines how the devices should be placed optimally within the vertebrae, what the optimal size of the instrumentation should be, and to be able to do so throughout the lumbar spine, to automatically localize instrumentation as it's delivered, so we know what devices are being delivered to the patient. We're able to analyze models and accurately localize where the instrumentation has truly been delivered within a patient, and then analyze the deviations. For example, the deviation between where the instrument was delivered with where we thought it should have been delivered optimally, and any deviation there, and also to detect complications. The intersection of the space of the screw with the vertebrae might tell us that we actually breached the cortex of the vertebrae, and that might give us an important feature on whether that's going to cause problems for the patient. So we pulled that together in a preliminary study shown here, where we did a small study involving 64 patients receiving 84 surgeries. And you see some of their clinical demographic status summarized here. And over here, you see some of the image analytics that were extracted from each patient's perioperative data. And so grouping those, we combined these clinical features and quantitative image features into a machine learning method called a boosted decision tree. This is basically a type of machine learning method that takes each one of these factors in themselves as a weak predictor, but is able to combine them in a way where an ensemble of weak predictors could give a strong prediction. Based on just the demographic data alone, as you see here in this plot of the sensitivity of the predictions versus the 1 minus specificity of the predictions, this diagonal line basically represents the line of pure guessing. And so in this limited study with just these limited clinical features, we reproduced the concept that we're not getting strong predictions of patients' outcomes. But by bringing in image information from the preoperative data, we were able to improve the accuracy of those predictions a bit, upwards of 71% based on the preoperative and intraoperative images. So by the time we're completing the surgery based on their intraoperative images, we have a much better idea of the outcome of a particular patient. And if at 3 months, and if we extend that on to 12 months, we were doing even better, whereby combining image information into the predictive model, we were able to increase the accuracy of predictions up over 80%. The really interesting thing about Spine Cloud is when you go back to the decision tree and ask, what were the features that were shaping the prediction? What was the importance of the features? And you go and analyze just the top 10, the importance of those features is shown here. Image-based features are shown in green, and clinical demographic features are shown in white. And you see that the top 9 out of 10 of the features that were shaping the prediction actually came from the image data rather than the clinical demographic data. So that suggests that we're on the right track, that there's a lot of information that can be extracted from the images to improve the prediction. So the big pictures of a decision support network is illustrated here, where you see the inputs to the system are what I've described, a predictive model. This is a simple one, and we're working on deeper neural network approaches that we think would have higher predictive value. And the type of clinical decision support tools that we anticipate are shown here. Selecting candidates for surgery, knowing who is more likely to benefit from surgery, optimizing the treatment plans that are delivered to those patients based on evidence, and shaping patients' rehabilitative, or helping to shape their rehabilitative pathways. I'm just out of time, but I want to invite you to think about how that concept of image analytics and quantitative image-based features could serve other areas as well. I talked about spine surgery, but Todd McNutt has talked about this for some time, and how the spatial relationships of structures and images can be used to predict outcomes in radiation therapy. For example, dry mouth in head and neck surgery, able to discriminate patients who will or will not experience poor outcomes in radiotherapy based on image analytics. And what we're looking at now is how image-based features quantitatively extracted from chest CT could understand the genesis and progression and treatment response of COVID-19, and also other disease sequelae that are almost certain to arise in the very large population of people who have been afflicted with this disease and have recovered. There are 2 high-resolution CT systems in North America. One of them is at Johns Hopkins University. The other is at University of California at Davis. And I'm just showing an example here of what the boost in image content looks like for these kinds of images. And what I want you to ask yourself is, or to imagine are the quantitative features, not only of the disease, but also of the normal lung. And if the extraction of those features could help drive predictive models that are more patient-specific for COVID patients. All right, I'll conclude there just to say that imaging and image analytics are describing a new role in precision medicine and helping complete the continuum of measurement that Dr. Rosen described. In a surgical context, it moves the precision paradigm from that of millimeters of precision to the individualized patient-specific. And moreover, notice that the predictive models were explainable. We could understand what it was about the patient that was determining their outcome. And therefore, these systems could be actionable. We could identify features that could be changed and make a patient a better candidate for surgery or improve their therapeutic trajectory. I want to thank the collaborators at Hopkins, including Nick Theodore, who is the head of neurosurgical spine and co-directs the Carnegie Center for Surgical Innovation with me, as well as all the engineering students and clinical collaborators. Thank you very much.
Great, thank you, Jeff. We're pretty much out of time, we're a little over time. So I'm just going to actually quickly compress two questions from the panelists. One is from Cindy Hoffman, the other is from Cynthia Saver. So what is the rate of use of this high-level imaging, and are surgeons actively using this at the moment?
Thank you. That's a great question. And I'm happy to say that everything we've done so far uses images that are already acquired within a patient's normal standard of care. So a patient going through a normal diagnostic workup, those are the kinds of images we would use as preoperative. And if a patient is receiving surgery, there's imaging acquired in the operating room that is fairly mainstream, even if it's intraoperative radiography. Those are the kinds of images that we use as input to the models.
Great, thank you.